I'm Rachel Cole. I am a pediatric sports medicine specialist. I have um, met many of you before, and many of you I haven't. So please always feel free to reach out to me. I'd be happy to answer questions about this topic or any other in the future. I work at Kapiolani, but I'm actually mainly based out at our Straub Kapolei location, which is out on the west side. And so we've kind of got clinics all over, but that's where I tend to be. But I'm happy to answer questions about anywhere. Today, I want to take you through overuse injuries in kids because it's unique and there's a lot of things that maybe masquerade as diagnoses we might consider um, for adults, but actually these are things that are happening in kids, and also importantly, we kind of label them as the thing that happens in an adult, but actually it's a totally different diagnosis because it's a kid and it's a kid's body. So we're going to go over all of those things today. Um, so let me move here. I don't have any disclosures or commercial interests within the last 12 months. Truthfully, within the last 20 something years, which I wish I did, but I don't. Um, so what do we treat? So for me, I see everything, all things sports for kids, but that doesn't have to be necessarily a kid participating in athletics. So yes, we see sprains and strains and fractures, but somebody might get a concussion. We're going to see them even if that concussion happened on the trampoline in their backyard or if they slipped on campus at school. So we see it all: neck and back pain, even scoliosis in towing and toe walking. We try to get people in very quickly. It's been harder and harder as we've gotten busier and more short staffed, but we try to make it same day or next because these are usually acute things or things that are really worrying parents, and we want to get them in quickly. Um, Dr. King, Dr. Lynch, and I are all fellowship trained. So there's a sports medicine fellowship. I specifically did one that was pediatrics focused, but it originated in the field of family practice. So I was lucky I got to do one that was really about 75, 80% pediatrics at the University of Colorado, which was really great. And then, as you know, we partner with other people. So we partner with physical therapy and our surgeons as a group to try to make everybody well if we can and keep them active. Um, so we already went over the objectives. I won't review them again, but in general, I really want to help you understand why exercise and fitness is important for our kids, and then look at how, though, that can actually sometimes get overdone, overblown, and then create injuries, which we would call overuse injuries, which are different than acute injuries, and then hopefully end on some cases to really drive it home. Um, so this may all seem really common sense, but it's actually really interesting to learn about how our sports benefit our kids. Um, we know that it makes them healthier and happier, but interesting to find out that that dumb jock stereotype is not true. That actually it makes kids better students. It actually develops better leaders and overall better citizens in our own communities. We've seen direct links between exercise and physical activity and things like reduced risk of cancers, such as breast cancer, um, decreased risk of osteoporosis, heart disease, obesity, suicide, and anxiety. So many, wide-ranging benefits. Really interesting. This is a pretty interesting study that was done looking at the brain on the left after sitting quietly versus after just going for something as simple as a 20-minute walk. And what this basically shows us is that when we move our body, we activate our brain. That even we don't have to be running, we can be walking. But when we're doing that, this study out of the University of Illinois showed that it actually stimulated neuroelectric activity in the brain. And that activity is going to lead to, again, better outcomes, higher self-esteem, fewer depressive symptoms, better social skills, increased competence, and then they learn how to set goals. They learn leadership skills. So some interesting facts you may or may not know that male athletes, if you look at them compared to those who are not athletic, male athletes are more likely to eat fruits and vegetables. They're less likely to smoke, use illegal drugs, carry a weapon. Teenage female athletes, research has shown, compared to those who are not athletic, they're more likely to have good body image, higher test scores. They're more likely to volunteer in their community and register to vote. They're more likely to follow the news. They're more likely to push out their first sexual encounter to later into adolescence. 41% more likely to graduate from college. And interestingly, if you're exercising, you're more likely to influence your children to be exercising because we've seen that those who are active as children, many of them have physically active parents. Um, just like the boys, teenage female athletes less likely to use drugs, be suicidal, smoke, or to get pregnant. And so this is a really common pictograph that many of us have seen out of the Aspen Institute that is just kind of a nice pictorial of what happens with physically active children. They're less likely to be obese. They have 40% higher test scores, 15% more likely to go to college, 7 to 8% higher annual earnings, and then, you know, higher higher rates of achievement and lower rates of disease and morbidity. So if you ask kids why they play sports, they'll tell you, if you look at the common surveys, and this is just an example of one study, that they play sports to have fun. They like the fairness of sports. They like participating with their friends, and they like developing their skills. But interestingly, if you do the same survey for parents, their number one answer is winning, which may surprise some of you. And sometimes that winning can put too much pressure on kids. Sometimes there's other influences like screen time, school pressure, other things. But we've learned that if a girl doesn't participate in sports by the time she's 10 years old, she only has a 10% chance she's going to be active when she's 25. So what we do when we're young influences who we're going to be when we're older. And by age 15, 70 to 80% of teenagers are no longer doing sports. So there's a huge rate of attrition. So we want to find out sort of, what's driving some of this and how do we keep kids active. There's also a lot of underrepresentation in high school sports. So still there's disproportionate numbers of boys compared to girls who are playing sports. And especially if you look at schools that have minority populations, girls are even less likely to be participating. Asian American students tend to be less commonly interested in the sports that are offered to them. And there's this kind of is pervasive throughout multiple communities of minority adolescents, that there's less participation. And I kind of put this in here just interestingly that the average cost of one child's primary sport per season now has gotten to be so expensive that it's about $1,000 for just one season. And many kids are being pressured to play in multiple seasons. And if finance is an issue for a family, it's really going to, in some ways, disable that family from being able to allow their child to participate. But what are the recommendations then? If kids aren't playing in sports, are they doing it on their own? What should they be doing? Well, the recommended daily exercise recommendations are 60 minutes per day, 5 to 7 days a week. The how common is that? Well, only in elementary school, only about 42% of kids meet this goal, and in teenagers, that's only 8%. So again, regardless of whether you're playing an organized sport or just participating in these types of level of activity, we're really missing the mark. And so I want to also kind of switch gears to talk a little bit about sports. I just went over all these benefits, but we know that sports can hurt our youth, and there's probably something driving some of that, right? All this competition and so forth. So to give you a little bit of background, the amount of participation in youth sports, the amount of pressure for our kids to participate in youth sports has gone way up. So now between the ages of 6 to 17, there's about 27 million kids per year that are participating on some kind of team sport. But also importantly, 50% of all sports injuries are coming now in children from overuse, from overdoing it. So we're pushing them to play a lot of sports, and then we're seeing the injuries because of that. And really the face of youth sports has changed where, not everybody, it used to be that, there was a lot of medals for a lot of people, and, we could all find something that might be fun for us, even if it was just a tug of war. And back in the day, we had, women who were participating even though they had to leap over hurdles in skirts. Um, but we had people getting out there, and there was a fun element to it for some people and a competitive element for others. But now it's, we've got kids starting at very young ages. These are some famous athletes that you may recognize. Missy Franklin on the right, and Venus and her sister on the left. And they started very, very young, training to be pros from a very, very young age. And that's pretty common, and has put a lot of pressure on even little kids. The intensity has changed. I can tell you, for me, just as a practitioner in sports medicine, the amount of pressure I hear put on a lot of my patients from the parents about, their kid is going to be the next NBA player, next collegiate athlete, next Olympic athlete. Um, I just saw somebody yesterday who, I need to fix his knee right now, need to fix it right away because he is going to be, the next NFL star. But he's 12, right? So it's great that he has these ambitious goals, but at the same token, that intensity can spur them on to injury. Um, and so we've got kids doing amazing sports, but they're competing at very, very young ages and putting in long, long hours. And I can speak to this when my children were both born when I was still in Denver, after my fellowship, and we had all this pressure to enroll them in soccer, and I mean they could barely stand on 2 feet, and they were, running up and down soccer fields chasing after a ball that was bigger than them. And for what? I'm not quite sure at that age. Free play is really probably equally, if not more, valuable. Um, I thought this was interesting, and I just wanted to kind of put this in perspective as well. So a lot of us have patients where, again, it's great that they have goals, but we also don't want to put so much pressure on them to, practice, 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 practice in order to try to make some of these goals of getting a college scholarship or making it to the pros. So if you just look at the numbers, um, what are the odds of a high school athlete making it to an NC2A Division I college sports team? Less than 2% of high school athletes across the country. Um, Maybe any division, not just Division I, but Division I, II, or III varsity college sport, only 7%. So that's not, that's including schools that don't even offer scholarships. What about the pros? So the number of high school athletes in America making it to professional sports is 0.00625%. So 1 in 16,000 will make it to the professional level of their sport. And for Olympic sports, it's even less. It's 0.0002%, which is 1 in 500,000 high school athletes are going to be participating in an Olympic sport one day. So to give you some perspective, think about our population on island, and just think about that. We have about 750,000 people on island. And so if you start thinking of those numbers and the number of high school athletes, I believe in the state we had like 50,000 high school athletes per year in our whole state. And so really, um, one or two of them are going to make it to the pros, and and again, very, very few of them at all. Every few years we might get somebody who's going to make it to an Olympic sport. And I don't say that to be a Debbie Downer. I say this to just, again, when I have people coming in pushing, pushing, pushing their kid, um, honestly, some free play would be great, or another hobby, or exploring a different extracurricular is equally as valuable. And, again, the amount of money that these families are spending, I'm not sure of how many of you are familiar with the type of programs that are out there now that create videos for the athletes to then submit to schools for recruiting, the number of travel camps they go to for recruiting trips. And so parents are paying tons of money for the coaching, for outside coaching, and then for the travel, and then for thousands and thousands of dollars, up to about $15,000 for recruiting videos that they can then submit to these coaches. So it's become a big industry, unfortunately. And so with all the sports participation, yes, we do see acute injuries. So this is an acute injury, right? Like a fracture that you see on the left, or an elbow dislocation like you see here on the right. These are things that can happen. They're accidents. No one plans for it, of course. And even if you are very good about how many hours you put in, you can still have these acute injuries. But that's in contrast to overuse injuries. So, what is an overuse injury? It's a chronic injury. It didn't happen just because I stepped wrong or I fell wrong. It's from a constant high level of physiologic stress. And in essence, think of it this way, that our body is kind of trying to always stay in balance. But if we're loading the body, then we need to have time to recover, right? Good sleep, good nutrition, managing our stress. Um, but if our load keeps exceeding our ability to recover, that balance is going to be out of whack. And we end up having this unresolved stress on our tissues, that these tissues were previously normal, but they can't get back to normal because we just keep loading them and loading them and loading them. So that kind of idea of pushing through pain or ignoring our pain, that's the concept of an overuse injury. And so again, think of it as tipping the scales in the wrong direction. So there are four stages of overuse injury. So initially what you'll hear from a patient is that, it started with just it hurt when I was doing cross country. Only when I was running, I felt the pain in my shins. And then it becomes pain um, during the activity. Um, uh, I'm sorry, I should have misspoke. So the first pain is just when it's after the activity. So it doesn't hurt me when I'm running. It hurts me when I'm done running, but then I wake up the next morning, I'm okay. The next stage is it's during the activity, but I'm still able to keep up. So yeah, I'm able to keep up with the other runners, but I do have shin pain while I'm running. And then the third phase is going to be during the activity, I'm having pain, and now my pain is so bad that I can't keep up. I'm limping, or I'm having to slow down my stride or change my stride because it's hurting so bad. And then the ultimate or fourth stage of overuse injury is going to be this chronic sort of unremitting pain. So even when I'm at rest, my shins are aching me. So I run, I hurt. I go home, I hurt. I wake up, I still hurt. That's when we start to get especially concerned. So, what are we talking about as far as the structures at risk? So, the structures at risk that we want to talk about are the bones, the growth plates, the muscles, the tendons, and where those muscle tendons meet, because those are kind of our weak link. Right? Hold on, it froze on me. Here we go. All right. So in particular, pediatric bone is really vulnerable to these overuse injuries. So I won't bore you with all the anatomy of the bone, but essentially right around the growth plate area is our weak link, and it's where they're going through rapid periods of growth, and those areas of growth are structurally the weakest. They have a little bit more cartilage, a little bit more flexible, and can be susceptible to damage more easily. So what can happen over time, and it's a little bit of a blurry picture, so I apologize. But one of the things that can happen is, going from a normal growth plate kind of looks even across the space to some widening, maybe asymmetrically, to ultimately separating or tearing. Some examples of chronic injury, we can get joint overload, where just using that joint over and over again, it starts to ache, like patellofemoral pain syndrome at the front of the kneecap. We can get stress fractures, where again that balance is off, and so we're loading, and we're not recovering, and eventually the bone gives way. We can get something called apophysitis, which some of us have heard of, like Osgood-Schlatters disease or Sever's disease in the heel, which is overused to these accessory growth plates. These plates don't make us taller, they make our bones thicker and stronger. We can injure the growth plates themselves, like little leaguer's elbow or little leaguer's shoulder. We can get tendonitis. And then ultimately, there's even sort of that mental health aspect of it, where athletes can get burnout. They're just overtrained, and they've kind of just so fatigued physically and mentally that they just don't want to participate anymore. So if you haven't heard of burnout or overtraining syndrome, it is real. I recently saw a swimmer who was a teenager who just was burnt out in all aspects. And it is really, truly a psychological, a physiological, and a hormonal effect, where they start at first to see decreased sports performance. So no matter how I try, I just can't seem to perform the way I used to, and then they start getting aches and pains. They often will find that they're having some personality changes, most commonly a lack of enthusiasm, some symptoms of depression, maybe feeling really anxious, some anxiety, before their events, and almost having panic attacks. And then, interesting on the physiologic level, it literally creates an elevated resting heart rate, that their body is physically under stress from this overtraining, and they'll see changes in heart rate. And that's one of the classic things that we can look for as physicians. Um, they'll have often fatigue or fatigue syndromes where they're, kind of chronically fatigued. Um, and then you'll start to see it kind of invade their personal life. Their quality of life decreases. They're having difficulty completing their usual routines. So in our students, we might see decreasing grades, or if they have a job or a club they participate in, they're skipping, they're missing. They just can't keep up. Other types of chronic injury. So I mentioned to you apophysitis. I don't know if you're familiar with an apophysis, if you've ever heard of one. And so this is kind of a multiple choice, situation here, where, what is it? And what it is it's not an accessory bone, and it's not a piece of bone that has broken off, and it most commonly is misidentified that way on X-ray. Um, but what it is a secondary ossification center where muscle tendons attach. So the muscle transitions to a tendon, like the Achilles tendon in this picture, and then it attaches right at the heel bone. And that's conveniently where we've been designed to grow at certain ages when we're young, in order to make that bone thicker and stronger, so that as our muscles grow and get thicker and stronger, let's say at 10 or 11 of age, then our bone has to get thicker and stronger to handle that tugging, that traction load on the bone. So apophysitis is just inflammation, itis, inflammation of an apophysis. So if we repetitively use a certain muscle group, it's going to be repetitively pulling on that area and creating a traction injury to that area, just like you see in this picture. A little bit hard to see. This is a sagittal or side view. So our quad muscles are coming down, attached to the patella or kneecap. And then this patellar tendon is pulling right here at the tibial tuberosity. And this is what we would know as Osgood-Schlatters disease. Um, it's going to be exacerbated in kids who are particularly tight. So if they're inflexible, that can be a problem. And it's going to be exacerbated in kids who are using it all the time. So when you look here, this is what Osgood-Schlatters looks like, which is just you have to have a growth plate there to have irritation of a growth plate. So this is what the apophysis can look like, and it can be really varied. It can look like it's almost broken with some little fragmentation, or it can look like it's almost lifted up. But that actually, to me, looks like a normal growth plate. I couldn't tell you if they have Osgood-Schlatter until I heard their story and examined them. So just having the growth center doesn't give you it. You have to have the repetitive injury to it. Lots and lots of sites of apophyses. So we have them in our heel, in our calcaneus. We have it even in the base of our fifth metatarsal, which is known as Islin's disease. We have it in our tibia, again, Osgood-Schlatter. We have it at the bottom of the kneecap. We have it in the pelvis even, at various locations where, for example, at the iliac crest, that's where our abdominal oblique muscles are. And so I've seen athletes who injured the apophyses, like sprinters who are kind of moving their arms and coming out of the blocks really quickly. These different locations all have different muscle groups attaching there that could pull on them and injure them. Even in the shoulder at the acromion, and even in the elbow, we have them. And so all of our muscles, like I said, attach in different places and pull. And so interestingly, I just saw a young man yesterday who was a soccer player who kicked a ball and felt a sudden pain. And he actually injured with his hip flexors. He injured one of his growth plates at the anterior superior iliac spine. So he injured his sartorius. So this is what it can look like. So I mentioned to you sprinters. So this is a common one where if you look at where the red arrow is pointing at the top right of your screen, it looks different than the left side. So an apophysis can look crazy. This is the iliac crest apophysis. And if you look at the X-ray, the The x-ray here shows a normal looking apophysis on the left side of the screen, and on the right side, you can see a big gap here. So literally the abdominal oblique muscles pulled a piece of the bone off and widened it. And you can actually see if you keep following this piece down, you can actually see it, the whole thing just shifted, and here it is down at the bottom. So the whole thing kind of rolled down. And this is called a iliac crest avulsion fracture, apophyseal avulsion fracture. Um, this is what a normal one would look like if you look down at where the hamstrings insert. So if we come down over here at the pubic rami, you can see this is where the hamstrings insert, and it looks symmetric on both sides. So the beauty of the pelvis is that we got two sides, so we can compare them. So if you want to diagnose this and somebody's coming in with left-sided hip pain, my suggestion to you is to x-ray an AP standing pelvis, so you can see both sides, because now you have Mother Nature to help you on the other side so you can compare. So what are our risk factors for overuse injury? So these are common ones to look out for. So if you have an athlete who is specializing really early, so I see this a ton in our baseball kids. So our boys who, or girls, girls can now play with the boys on the baseball teams, but especially our throwers who are now becoming pitchers at age 6. And I'll talk to these parents and they'll be like, yeah, no, Johnny can't rest his elbow because he's got a tournament, and then we're flying to New York for another tournament, and then we're going to Vegas for another tournament. And I'm like, he's 6. I mean, like what? So if they're only doing one sport and one position, particularly in that sport, that's going to be a red flag for you. Year-round participation is also a red flag. So not having an off season. I always tell my patients about, when I grew up here in Hawaii, I had off seasons. We had soccer and then I had paddling. And so I was getting two different sports, which is great, different muscle groups. And then I'd have an off season where there was neither of those. And then I had surfing or, go out to play with the kids on the street, and we'd skateboard and climb trees and get into trouble. Um, but they're not getting that. If they don't have an off season, they're just going year round. Their body is using the same muscle groups over and over and over again and pounding on the same bones over and over again. Playing on multiple teams is also going to be one of your red flags. So a lot of kids, they play club and they play school, and sometimes they play on two clubs, especially if they're good athletes. They're going to be pressured. Coaches want them, teams want them on their teams, and there's a fear of missing out. There's a lot of keeping up with the Joneses in sports these days. So if you don't play, if you take an off season for yourself and say, sorry, I'm going to skip this club season and rest this one out, you might actually lose your position and not be able to get back on the team. They might give it to somebody else. And so a lot of these kids feel a lot of pressure to keep up with it. And truthfully, it's not just the kids, it's the parents as well. um, Overlapping seasons. So a lot of times what happens is their school season is ongoing, and they want to, they're a football player, but they also play baseball and their club baseball is starting up. And so they'll do both at the same time. And so they're just getting too much exercise. There is a policy in our state high schools that you cannot play your same sport, school and club at the same time. So if you're busy playing, Iolani soccer, you can't also play club soccer at the same time. You have to wait until your school season ends before you can go play on your club team. It's meant to protect them, but again, they'll find other ways. Tournaments are also a red flag. A lot of these tournaments, if you follow them, they're 2, 3 days. They're playing 4, 5, 6 games in a tournament. It's pretty rough. Their body just doesn't get any rest. They're often on the road, so they're disrupted sleep. They may not be caring for their nutrition the way they might normally. And then, these kids who are on these elite and traveling teams, again, they're just being pushed to go, go, go and make it to the next level all the time. And then there's this mentality of overtraining, which is if a little is good, more must be better. So I can't tell you, I just saw a boy this morning who wants to get really, really good at pitching. And so he plays for his team. And I asked them, well, how often do you practice? Oh, 3 times a week. How often do you play games? Well, once or twice on a weekend. Okay, so now we're up to 5. And then I said, but do you ever throw on your own? Oh, yeah, every day. I go out in the backyard with my dad and I throw every day. So you need to be asking about what they're doing on their own time because they don't always see that as practice. But that overtraining can be a huge risk factor. So it's a great question to ask, which is, what are you doing on your own to practice in this sport? Oh, and I should also say a lot of them have personal trainers now, or they go to performance training, and so you want to ask about that as well. Are you, you might not, you might only be only practicing 4 times a week, but then in the other days that are quote unquote recovery days, they're going to their strength and conditioning coach, and so it's not a recovery day. Um, the athlete at risk in particular is going to be the one who does a repetitive sport. So your gymnasts, your runners. Um, it's going to be somebody who doesn't have great mechanics, so somebody who's not familiar with a position and gets switched into it. So they were never a pitcher and now they are, and so they're throwing with poor mechanics. It's also the person who's had a rapid increase in their activity. So somebody who wasn't previously a cross country runner, but then decided to try the sport. That's wonderful. But if they hadn't trained for it all summer and all of a sudden now they're, hitting it with the team and they're running 3 to 5 miles a day, which is literally what happens with these kids, um, that rapid increase is a great risk factor for injury. Um, and then think about your type A, right? So your elite kid who just, they want to keep up with everybody. They want to be the best. Those are the kids I worry about a lot as well because they're not going to listen to their body. They want to push through to keep up and not miss out on practices. Um, Okay, so just before we get into the cases, I want to talk a little bit about how we treat these. So, um, what is treatment of overuse injuries? So the first is that we got to get to the right diagnosis. Like I said, a lot of times people want to attribute adult diagnoses to kids. So an example being that they'll say that they have maybe patellar tendonitis, which is a tendonitis of the knee, but actually maybe it's Osgood-Schlatter. So we need to get to the right diagnosis. We want to look at what are their risk factors. So asking the right questions to figure out, oh, wait, you're not actually just going to practice 4 times a week. You do have your strength and conditioning personal trainer 3 other times a week, plus you go and throw in the backyard on your own. Okay, so we got to really cut back on your activity. It may not be activity related, it may be other things. It may be their nutrition, it may be other things to consider. Um, Sleep. I'm going to emphasize that right now. If you're not asking about sleep, you want to start asking, especially your adolescents. But I'm finding younger and younger kids are up late at night on their screens. Parents aren't sure how to get the screens away from the kids, or the kids are taking them back. But sleep is really disrupted these days. And we started adding it to our sports medicine intake form here at Kapiolani. And um, I would say fascinating, but it's actually really depressing that a lot of our kids are getting, our high school kids in particular, are getting 5 to 6 hours of sleep a night. And that's not recovery. That's not recovery mentally, and that's not recovery physically. So if you're not asking, it's a great thing to put on your form because it's a great entryway to talking about health and setting patterns that are healthy for the rest of their lives. Um, Symptom control. So, what does that mean? That means, well, they might need a period of rest. We might need to talk about icing or anti-inflammatories or using correct bracing. And then ultimately, a lot of this is going to take some physical therapy, but progressively, we're going to start really light, start easy, and build them up in order, and as their body tolerates, in order to achieve muscle balance, muscle endurance, and then the right mechanical skills. A lot of physical therapists are good at a particular sport. So, oh, you're a thrower. I like to send you to such and such PT place because they'll put you through a throwing program in PT. That can be really helpful for sports specific type PT. And then ultimately, we're trying to treat something, but it'd be really nice if we could just prevent it from the beginning and kind of set the stage for appropriate levels of activity and recovery and so forth. So there are specific recommendations. These actually come from our AMSSM, our American Medical Society for Sports Medicine. And the recommendations are that our maximum sporting activity should be 5 days a week. So 2 days of doing something else. Even if they want to be active, that's great. But if normally I'm playing soccer, I go surfing or I just go walking with my family, but something different. Um, Minimum, we want one rest day a week. So even if they're going to do something different, they should just still have a day a week where their body just does nothing and they can do some homework, they can get to bed early, they can hang out with friends, they can go to the movies, but something where at least one day a week their body just gets to recover. And then seasonal rest, so 2 to 3 months off per year. Now, that doesn't have to be all at once, like they take all summer off of sports. In fact, that's really difficult to do these days. And in fact, you're not going to convince anybody to do it. But if you can ask them to take a couple weeks here and a couple weeks there and really let their body recover, maybe cross train, that is going to be the best for the body. And truth be told, these are the same recommendations for adults. So if you're not doing these things, and you participate in a sport and you're grinding it out all the time, you're setting yourself up for injury as well. Um, and then the max training increase that we recommend is 10% per week. What does that mean? Well, think about like your kid who's never done cross country before, or your kid who has but didn't prepare for it and just shows up cold turkey. And all of a sudden they're going from 0 to 60 and they're just doing a ton of mileage. Like I said, what you really want to look at is a 10% increase. So um, and I put that as a rough, that's the actual recommendation, but I always look at it with patients as a rough number. So if they haven't been running at all, then have them start with like a run walk where they, um, you know, walk 5 minutes, run 1 minute, walk 5 minutes, run 1 minute. And then the next week, they do walk 4 minutes, run 2 minutes, and they start changing the ratio of how much walk to run or how many days they go out into a full out run. You can start calculating it out. Okay, if you're doing this amount of mileage, 10% increase means, you were running 1 mile a week. Now you're going to run 1.1 miles a week. You can, but I think a little gestalt is fine. But in general, that it kind of hones people in. Um, we recommend only participating on one team per season. I'm sorry. And then the other thing that didn't end up on here is that it should actually also say that there should be some cross training, that ideally we're using different muscle groups throughout the year. Um, so the other thing that you really want to emphasize with your kids is that the sport should still be fun for you and that it should be teaching you teamwork and sportsmanship, that yes, it should be about fitness and strength and so forth, but there's also skills you're learning safety and how to move your body well, and then you're learning about how your body works. And if sport has changed from that, we need to look at what we can do to make it return to these things. Is it a break that they need, or is it something else? But we want to work with them on again, making sport fun and making it beneficial. It's going to be one of your best ways to avoid burnout. So again, the other ways are thinking about cross training, that if they're just driving swimming all the time, swim, 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 and they do nothing else, they're going to burn out. Um, they need some days off and they need some months off. Making sure to have those difficult conversations with athletes. Often I have the parents step out of the room because they do get some parental pressure or they want to please their parents, so they are saying what they think they want to hear. So I talk to the adolescent alone if it's a older kid about why are we doing the sport? Do you still want to do the sport? Are you thinking of quitting? I try to frame it in a positive framework. Instead of asking if they want to quit, I usually say, is it something you're still enjoying? Is it something you still want to do? Um, I make sure they're hitting their nutrition and hydration goals, and I talk to them about limiting tournament play, um, and then looking at their other stressors. So if they're a junior in high school and they have all of this pre-college stress going on, they're worried about applications and where they're going to go. And then in addition, they're trying to practice morning, noon, and night. It can be really stressful. So helping them kind of, okay, well, where can we cut back? Where can we take things out? How do we start saying no to some things? And then again, similar to cross training is finding other outlets that if they are a little bit burned out, can we redirect for a little bit to other things? We can always revisit swimming and come on back. So in the last minutes, I'd like to go over some cases and just, again, give you some examples of what it might look like and when to manage it and when to refer it to orthopedics. So our first case is knee pain. So we have a 10-year-old male. He plays soccer and he's had 4 months of bilateral anterior knee pain, so front of the knee. There's been no trauma and he can't really localize it. It's sort of like, yeah, my knee hurts. Um, he does get some swelling, but it's mild, and he has no mechanical symptoms, which means it's not locking up on him, it's not buckling or giving way. And on exam, both knees are kind of the same. There's no swelling that you're going to see that's significant. He's got good motion, but he's tender over what's called the medial femoral condyle, so the medial distal aspect of the femur, and he's tender over the joint line, which is also where meniscus lives. So we're going to maybe put that on our differential. But again, he hasn't had any injury. Um, when we check him, he doesn't, his kneecap doesn't bother him. He doesn't have any apprehension when you move it. You do all the stress testing for the major ligaments, and they're all negative. But he does hurt when you do meniscus testing. So something like a McMurray test where you kind of rotate the knee. He's got some pain on the medial aspect. And this, in this case, is something called osteochondritis dissecans. It's also known as OCD, but not obsessive compulsive disorder. OCD is, we believe, a microvascular injury to the growing epiphysis, the growing end of the bone, where the blood supply from repetitive trauma is getting disrupted. So it's most commonly seen in active kids. Every so often I see it in a kid who's not active, but perhaps an unhealthy weight. And so that maybe putting some impact on the growth plate. And what you're looking at, if you look at the tip of these arrows, is this kind of moth-eaten appearance on X-ray of the lateral aspect here of the medial femoral condyle. And this is the number one area we'll find it. And you can see it here as well on this X-ray. There's a certain risk. If you have it in one knee, it's often good to X-ray the other side because they may have it bilaterally and just not yet have symptoms. It's potentially reversible. It's acquired, meaning there's different forms. I should clarify. There are juvenile forms and then there are adult forms. The adult form is typically traumatic. I stepped wrong hiking. I, jumped off of a bridge and landed wrong. But in the pediatric form, it's typically acquired from overuse, and it is more commonly reversible than the adult form, which really typically needs surgery. It's the bone underneath the bone, so to speak. So it's called subchondral bone. So all of our joint surfaces have this nice slick coating of cartilage, and below it, the bone has kind of rotted out. We think, again, probably from micro trauma and vascular injury. Overall, we still kind of call it idiopathic because we're not quite sure. 80% of them in the knee are going to be at that medial femoral condyle. And you can stage these by MRI to look at stability. So I won't bore you with all of it, but in general, the progression is from 1 through 5, staging on MRI, with as we advance, it becomes more and more unstable where first the cartilage is intact, but the bone is starting to become damaged and losing its blood supply. Then there's a fissure where fluid is getting behind it, but the piece is still in place. Now it's starting to separate. Now it's starting to completely separate. So maybe some of it was intact and some of it is separated at the cartilage level. Now even the bone is separating. And then ones and twos, we try to let them heal. I would refer these to orthopedics because it is a little bit nuanced as far as when do we let it heal and when do we do microfracture and other types of surgery. In kids, conservative care is often successful, which is we take away impact, we stop pounding on that weight surface of the medial femoral condyle. We can let them be active, but they swim, they cycle, they do upper body things, but we just get them from pounding on the legs, no jumping, no running. There is some controversy about whether something like this, which is an unloader brace, can help. These braces are actually originally designed for osteoarthritis in adults, but it can also unweight the medial femoral condyle. And again, may be helpful at the very least. It sometimes slows kids down, so that's good. And typical return to play here is about 3 to 6 months. How I usually manage this is that I put them on activity restrictions, and then every 3 months we re-X-ray, hoping for some good news. And if at 6 months we haven't seen any changes, we're going to go ahead and repeat an MRI, see where this thing is at, and think about doing surgery at that point. Things that are automatically going to take them to surgeries if a piece broke out and they have a loose body, that has to be removed. And then often they'll do cartilage grafting to help kind of heal the bone. And if it doesn't get better in 4 to 6 months of me trying, that's often, like I said, when I'm going to send it to the surgeon. So a second case of knee pain, we've got a 12-year-old male who's playing basketball, and he gets intermittent left knee pain. Again, no trauma, can't remember any specific injuries, but it really hurts when he jumps and kneels. When you examine him, he definitely has an enlarged tibial tuberosity. You note that he's really inflexible. This poor guy is so far from the floor when he tries to bend over and touch it. He's got real tight hamstrings. And when you go to palpate, he's really tender right over that tibial tuberosity. And on exam, one thing you could check is something called the popliteal angle, where it measures hamstring flexibility. You basically bring the hip to 90 degrees, keep the knee in flexion, and then you slowly extend the knee and you stop right when you feel your first resistance. All of us can push further and keep going and stretch out. What we're looking for is where's that first part that the legs wants to stop, and that's going to be their popliteal angle. Um, and so, again, somebody who, you have the gymnast who can go all the way straight, and you've got other athletes who can't barely get past 90 degrees. So again, it's a kind of a good way to look at their hamstrings. This is what Osgood-Schlatter apophysitis would look like, and that's what this kid has. So they'll have a bump at their knee where you can see the red arrow on the left picture, and on X-ray, this is what it'll look like. It's kind of got a growth plate, looks like a little nose growing off the bone, a little finger projection, but it is not a tumor. It is not broken. It is not a bad growth plate. It's just irritation of the growth plate because our quad muscles come down and pull on it. It can even look goofy like this. So this is probably what this guy would have, where it's, if you look, there's some soft tissue swelling. So there's swelling and deformity of the knee there. And then it's got this crazy beak-like fragmented appearance. That's not broken either. That is just a really mad tibial tuberosity apophysis. So the treatment for this is going to be relative rest. And we say relative because we do allow them to play through the pain. It's not particularly dangerous. It's just that it's just torturing themselves. So if they have a major competition coming up or a really big event that they want to focus on, and then they think they can pull back, I'll let them push through. But I do tell them that, yeah, if you rest a little bit and focus on some stretching, we can probably get this to quiet down quite a bit. Ice massage can sometimes help, so icing over that area. Anti-inflammatories. I'm not a huge pill pusher, so I really only use the NSAIDs, if they're really sore. I don't do a lot of pre-medicating before sports because I feel like I'm kind of hiding things. I'm masking things, and I'd rather know a little bit about the pain. But certainly, if they're like, I have Olympic trials, I've got to try out. Yeah, sure. Take some ibuprofen before you go. That's fine. And then bracing, it's a plus minus. If you look at the literature, it's about a 50-50 whether it helps or not. This is called a CHOPAT strap or patellar tendon strap. And the idea is that you put it over the patellar tendon, and it changes the forces going through the tibial tuberosity. And again, it's changing the forces coming from the quadricep muscles, which are the ones attaching there. There is a cousin of Osgood-Schlatter that you may not have heard of. It's called Syndig Larsen-Johansson, and it is an apophysitis, but it's at the inferior pole of the patella, and it can look equally scary, which is if you look at this red arrow pointing to what looks like a break in the kneecap, and I have seen so many poor little 9-year-olds misdiagnosed with a patellar fracture when it's not a fracture. They didn't have an injury. It's just been hurting with baseball, soccer, volleyball, you name it. And it's the same thing from traction from the quads, but particularly from the patellar tendon pulling down at an active growth center that's happening at the kneecap around ages 9, 10 is when we usually see it. And if you're not sure, send it to one of us to help figure it out. Now, can kids break their patella? Absolutely, but they have to have a story for it. Right? If they didn't fall and they don't have a really good story for it, no one hit them there, they probably don't have a patellar fracture. Heel pain. So a couple more cases and then we'll let you go today. So heel pain, we have an 11-year-old girl who's a gymnast and she's got a 2-month history of right heel pain with, again, no trauma, but it's activity related. She's training all the time. I don't know if you know, but in gymnastics, in order to get to the next level, they have to put in so many hours and acquire so many skills. And so as they get higher in level, they are putting in, 20 to 40 hours a week in the gym, like a full-time job. It's pretty intense. So this kid is tender with calcaneal squeeze, which is you push on the heel bone and you just kind of squeeze it on the heel bone and it hurts. And this is another form of apophysitis called Seaver's disease or calcaneal apophysitis, depending on who you are and how you want to say it. But this is what the heel x-ray will look like, where it looks like something's broken. But again, this to me looks like a very normal age-appropriate heel. These, again, we treat with relative rest. They are allowed to continue soccer, basketball, whatever it is they enjoy, and they can continue playing as tolerated. But really want to focus a lot on stretching. And one of the best stretches is what you see in this picture here on the bottom, Achilles eccentric strengthening. It works also great for Achilles tendonitis. So usually a kid has one or the other, but not often do they have both the heel hurting and the Achilles tendon, but it works for both of them. And what it is essentially you're getting up on tippy toes, like in picture A, standing on one leg and slowly lowering yourself down, lowering the heel down, like in picture B. And then when you get good at that, you're also going to do other muscle strengthening by starting on one leg and slowly lowering down with the knee bent. And what we're doing is eccentric means that you're strengthening at the same time you're stretching. So the way you think of that is like if you're doing bench press or you're doing bar curls, right? It's not just the curling up, it's the slowly lowering down of the bar. You're lengthening your muscle at the same time you're resisting, so you're building muscle while you lengthen. Um, Gel heel cups can be really helpful. I would caution that you make sure that you put it in both shoes, even if they just have right severs. You want to put it in both so that they're symmetric and don't start developing back pain or hip pain or something else from being uneven. But gel heel cups are great. We even have cute little pediatric sizes in our office, which are fun, but truthfully, they can go to longs and get any adult size usually works. I want to talk to you about this one because this is an interesting one. This is wrist pain in a gymnast. So we're sticking with the gymnast. Gymnastics goes up to level 10 and then it becomes like a kind of pre-Olympic level after level 10. And so we have a 14-year-old highly competitive level 9 gymnast. She's had right wrist pain for 3 weeks with no injury that she can think of. Her pain is worst with gymnastics and gets better when she rests. And she has a little swelling, but it's pretty minimal. And on exam, you don't see a ton of swelling, but she is focally very tender over her distal radius, right at the level of where her growth plate would be. And on exam, on x-rays, you have something like this, and it's very subtle, kind of takes a trained eye. But if you look at the right x-ray, right where that right arrow is, there's a little bit of soft tissue swelling, a little curvature, and a little widening of this growth plate right there. It's very subtle, but again, fits with her exam. And this is a stress fracture of the distal radius. And a lot of people haven't heard of this, but you can actually get a stress fracture there, like anywhere else in our body, also known as gymnast's wrist. And so it's a stress fracture of the epiphysis, and it's very common in elite gymnasts, and it can often cause early premature shutdown of their growth plates. And it's from the repetitive compressive loading. We originally started as four-legged creatures, but now we're two. And so what's happened is all of this pounding that they're doing on arms and wrists that haven't been used to it for, eons now, it can cause damage to growth plates. And so it's hard to always identify on x-ray. And so a lot of times we're going to make it also as a clinical diagnosis. They're treated often in some kind of immobilization. I tend to cast because I don't trust gymnasts, especially competitive ones. They're pretty aggressive about wanting to get back to training, and they can't take a cast off. And it's usually about 4 weeks of casting, and then we slowly have to get them back to sport. But it's a true fracture. It's just related to stress. And this is that same athlete, just to compare. About a month later, the growth plate had closed back up where it had been widened and where they had a lot of soft tissue swelling. It had closed back up. So they can heal really well. I'm going to go just quickly through these without talking too much because I know we just have a few minutes and I just want to share these diagnoses with you. So I wanted to share with you about a shin pain athlete, a 16-year-old female runner with 4 weeks of shin pain with no injury. And she's so painful now she can't run due to the pain. And when you palpate her, she's sore over the tibia. And this is a test you can do called the one leg hop. So just have them jump up and down on that singular leg. And if it's hurting, it's probably worth at least getting an x-ray, if not an MRI. And she had a tibial stress fracture where you start to see bone reaction. This fuzzy stuff is bone reaction, where the bone's trying to heal itself while she keeps running on it and re-breaking it. And on MRI, you can actually see the crack. So not only can you see the swelling of the bone, but you can actually see a crack there that didn't show up on x-ray. And that's very common that MRI will be able to pick it up. You don't have to get a bone scan. If you did, you would see it light up, but it's kind of a test of the past for stress fractures because we have MRI now and that has no radiation. Those I'm going to put into a boot, and I'm even going to put them on crutches if it hurts still to weight bear in the boot. Otherwise, I'll let them walk. Um, and it can be a good 2 months, 2 to 3 months before they're back to full activity. And in the interim, what's really important and what I wanted to stress about this is you need to talk to anybody with a stress fracture, particularly your adolescents, about their bone health. In girls, are they getting their periods regularly? Do they have some kind of disordered eating? What is their diet like? What is their exercise regimen like? Are they, super intense? Are they restricting calories? And I see this both in boys and girls. So again, either gender, it's really important to ask these questions. I won't go into that as much. I do want to emphasize that we can see it in all aspects of the body. So as I mentioned to you, baseball pitchers are particularly vulnerable. And what it can look like is something like this, where it's really subtle, but on X-ray, if you look where this red arrow is, this is little league shoulder, where the growth plate has literally been ripped open. And if you're not sure, just get a comparative X-ray. Now this is the right side that's injured, and the left non-dominant side doesn't have that widening of the growth plate. So I do want to point out that it can happen anywhere in the body, and that's called little league shoulder. And we really restrict throwing for about 3 to 6 months. There are guidelines for throwing that we follow, and that we'll educate patients on to follow. And then I wanted to show you what it can look like when it starts to heal. So this is 3 months later, and that ripped open growth plate is now starting to come back together. So it can be really successful. Um, it can happen in the elbow with widening, and it can happen at other places in the elbow, and it can even happen in the back, also known as spondylolysis, where this yellow arrow is pointing. They can actually crack their spine. Cheerleaders and gymnasts are common for this, where they overload the spine repetitively. I even saw a 9-year-old with this injury. So yeah, 9 years old with an injury that cracked her spine from doing too much of gymnastics, actually. So it can happen in very young people. So I'm going to wrap this up. I know we're limited on time, but I want to thank you for your time. And I want you to just keep your eyes open for athletes that seem to be burning out, athletes that seem to be getting injured repetitively, and your athletes that may not be allowing their body to recover. Start asking about sleep and start asking about that ancillary activity that they don't consider practice or don't consider games. Or they'll say, well, I only played in one tournament this month. How many days was the tournament? 6 days. Oh, okay, well, 6 days nonstop, right? So when in doubt, just reach out to us, ask us. I love to try to help you keep things in the medical home. So I'm happy to answer questions. I think they're always best in your hands, but we're here to help out and see them for you if you think it's appropriate. And then I do have a whole list of references if you need it.
Thank you so much, Dr. Cole. I'm going to go ahead and launch our post-session questions. I know some of you might have to jump off, but if you can, the rest of you can stay on, whoever can. And Dr. Cole, do you have time to stay on for the questions?
Sure, I have a few minutes. I'm supposed to be in concussion clinic, but I can give it a few.
Thanks.
All right, I love that. Literally, the second I turn on my audio, my pager goes off. I feel like it was just waiting for me here.
Yeah, that's
I
right.
agree. Thank you so much. We'll see how quickly we can get through these questions so that you can hopefully answer any of the ones we did not get correctly for us. But thank you so much. I agree. That was an excellent presentation, and I really, really appreciated all the helpful tips on which questions to ask, the little things to look for that maybe we're not necessarily paying attention to all the time, especially in our athletes, and in just all those cases as well.
It's just so crazy how our baseball community, how strong and serious we're taking
Hmm,
it at a
yeah.
young age.
And really for us, so when I was in Denver practicing for 7 years, we would see things by season, right? So because things happened by season. So I would see, ski injuries and snowboarding injuries, and then we would see the baseball injuries because they couldn't play baseball in the winter. Um, but then I came here, especially, and in warm states in particular, it's just happening year round. They just don't stop. And so the pressure is on for these families to keep up. If you're a baseball family, and it's just I see it by seasons as well. When I see baseball really ramping up, boom, I'll see a bunch of elbows again. And then when volleyball's, up, I see a ton of shoulders, and it just kind of comes round and around. So it's really unfortunate. I feel like in some ways we're stealing the kids' youth. They don't get their free play time and their time to do other things and explore the world.
There's a
They're planning. Yeah.
There's a
Go ahead.
question in chat about ballet. Jennifer, we did have a really good dancer presentation last year. I will try and find that and send that over to you. But her question is, do you see the same kind of injuries in dancers, particularly with ballet dancers and their feet?
Absolutely. And it's not, unfortunately, just their feet. We see those stress fractures in their spine from a lot of that extension that they do, or they're not ready for a point and they go up on point and they're loading bones that aren't ready to be loaded because they're not using proper mechanics. So we absolutely see this. It's also a sport, just like gymnastics, just like diving, where their body is on display. And so there can be more disordered eating, and because of that malnutrition, and they tend to be more type A. A lot of ballerinas are very good students, and so they just put a lot of pressure on themselves holistically, and that ends up between that and potentially lack of nutrition, lack of sleep because they're just driving so hard all the time. We do see quite a few injuries, unfortunately.
And I think the only question that might need some going over is number two. Oh wait, not yeah, maybe number two.
Sure. Okay. Um, Right. All right. So number two is asking which one is a risk factor for overuse injury. So we know that having an off season is beneficial. It's not a risk factor. Um, Delaying sports specialization until after age 16 is a good thing. What we want people to do is be a multi-sport athlete for as long as possible. And if you look at the numbers, 1960s, 70s, 80s compared to now, we had so many people who played football, baseball, basketball back in the day, and now they're just only football year round. And so, if we can, we want people to wait to specialize until 16 or older, just to allow their bodies to develop different skills, different muscle groups, different agility. And so that is actually a protective factor is delaying. And then playing in sports tournaments is definitely a risk factor because they just play, play, play. And then playing on one team at a time is protective.
Thank you. I sorry, I do have a question personally for
Hmm.
my own.
Yeah.
2 to 3 month break throughout the year, and it doesn't have to be consecutive, it can be broken up. Now, if they're a multi-sport player, can they take a break from one, or is it complete shutdown from both sports during that?
No, you raise a great question. So correct. We want them 2 to 3 months off from that particular sport. So if they, again, if they are a swimmer and a tennis player, they may end up with some overuse injury to the shoulder because they're both shoulder heavy. So it's ideal that if they have two sports they're interested in, that they're different. So a lot of times I'll see somebody who's a football and a baseball player, or a wrestler and a judo athlete, and that's okay because then they're getting different things at different times. But if they're a wrestler year round, that's a great way to get injured. And so putting a different sport into that 2 to 3 months would be fine as long as they still give themselves, a day off per week of everything. Just allow themselves to rest and a couple of days where they're cross training.
Great, thank you. And then there was a message in a private message thanking you for this, that you're so great. Can we please have her back? And Dr. Cole is so great. She always comes back. So you're likely to see her return. And we just want to mahalo you for always taking the time to share with us.
Oh, it's my pleasure. Like I said, any ways that we can help you keep your patients where you know them and you know their histories and they're comfortable and it's continuity of care. That's really our goal. We're probably putting ourselves out of business, but but truth be told, it's the best thing for our patients, right? That's what we're all aligning to do is to try to keep it so that our patients are the healthiest and have longevity. So anything I can do to help you out to keep it that way, I'm happy to do so. If you feel like you want to learn how to manage clavicle fractures or concussions in your practice, I'd be happy to help you out. If you don't feel comfortable and you want me to help out, I'm happy to take them on either way. But we just want to make sure that you know that we're behind you in whatever you do in your practice.
That's honestly, I feel like the perfect summary of what Echo is all about. So thank you so, so much again, Dr. Coel. I really, really appreciated it. This was a great presentation. I'm seeing lots of thank yous in the chat. And we'll let you get to your concussion clinic and everyone
Thank you.
finish their days. But thank you so, so much again.
Hi, you're
We'll be
welcome.
sticking in the sports medicine theme and talking about pediatric physical therapy during our next session.
Mahalo, everyone. Thank you.
Thank you so much.
Yeah.
Bye.
Thank you all.